Morning, folks. I'm Rick Singleton. I'm the Provost of Queen's College, and I welcome you to another in our Continuing Education for Clergy series program. We have some people gathered here at Queen's College for our session today, and there are people who are with us online by webinar, and there are people who are viewing this as a recorded session. So welcome to you all, wherever you are and when you're availing of it, and we're delighted that you are availing of this means of continuing education. And I ask you, if you have any topics or ideas or suggestions, not only topics but also presenters on particular topics, send them on to me, because we have interest in strengthening what we're doing here and look forward to your input on it. We'll just take a moment to have a short prayer, and let us pray. Today being the feast of St. Timothy and Titus, yesterday being the feast of the conversion of St. Paul, the end of the week of prayer for Christian unity. It's a wonderful time for us to pray and to thank God for the one spirit that we share, and that is a spirit of unity, a spirit of Christian unity, which leads us to want to know more about each other, to see ways to work with each other, and to work diligently and joyfully to bring about the kingdom of God. And we ask this in the name of Christ our Lord. Amen. Amen. So our session today is on pastoral support for people with depression and other mental illnesses. I have two presenters. I have the Reverend Derrick Bishop, who's an Anglican deacon, primarily at the Cathedral here in St. John's, but he's retired from Eastern Health as a nurse educator. A substantial amount of that work in the area of mental health. My memory of Derrick is mainly, and I always associate him with being the educator, and certainly the go-to person for education for pastoral care people. He's been generous in his time, not only in his employment time in Eastern Health, but lots of adjustment of his own schedule to accommodate us as well. So Derrick, thanks for the great collaboration you have and comrade you've been and colleague over the years, and especially for participating today. The other is the Reverend Dr. Curt, an employee of Eastern Health, hired from a rough competition by a rough director of pastoral care and ethics at the time. But a great screening process, and the joy of our efficiency is that we hired Curt to do it. Need I name who that director of pastoral care and ethics was with a reference like that. But Curtis works in the mental health and ethics department as a clinician, works primarily in mental health and addictions, or only in mental health and addictions. He works both at Waterford Hospital and in rural Avalon, and has a substantial focus on addictions and assisting clients, families, and pastoral care workers with their ministry to the clients and families. So both of them will present, and I'm going to open slides for Derrick and let you launch us into it with some general introduction about mental illnesses, I believe is the plan for the first part. So, if you see something glowing on your screen, folks, there's nothing to be afraid of. It's just top of my head as I'm getting closer to the screen is it this the one you want?
I think that's it, yes. Yes.
Okay.
You want paper?
Yes. Yeah, probably the first slide. I got some here.
Oh, okay.
Just go back. I got plenty here. Here we go.
Should do it.
Well, thank you very much, Dr. Singleton, Rick, for asking me to do this presentation. It's an honor to do it. I've done this sort of work for many years at the Waterford Hospital, and then, of course, with Eastern Health. And the presentation that I'm going to be giving you today has been actually created by a number of nurse educators within Eastern Health. Sherry Goss, a former colleague of mine at Chard, both of whom are working in the mental health program, and of course myself. So for a number of years I gave this presentation to all staff coming to mental health, particularly those who may not have a mental health background, so they can have a better understanding of the type of illnesses that our clients in the mental health program have. And I also gave it to the med students. So first of all, mental illness, why? What exactly is a mental illness? Well, mental illness is a not being possessed necessarily by the devil or anything like that. Like sometimes this we've in the past, and people are not witches and so on, but we certainly in the past, many people with mental illnesses were highly misunderstood, treated cruelly, particularly in areas where you have people with dementias and things like that, or schizophrenia, that they were thought to be possessed by the devil and often would be burned at the stake. And so we haven't had a very good history with treating people sometimes. But over the centuries, things improved. Today, of course, we recognize that there's a number of mental illnesses that people can suffer from. And it's basically an illness of the brain. It's a disorder of the brain resulting from changes in the anatomy, physiology, and chemistry of the nervous system. Neurotransmitters, now you've probably heard this word before, neurotransmitter, and one that's fairly common, you've probably heard is dopamine, or you may have heard of serotonin. And some of these chemicals that go between the nerve cells, the neurons, they basically are not, it's not working properly. You may not have enough of a particular neurotransmitter or too much and so on. So there's causes a disruption in the system, and of course it may lead to mental illness. Some people who have mental illnesses recover completely. They may only have one episode in their life, or when they're under a particular stress, grief, loss of job, or ending of relationships and so on, they may find themselves under that significant amount of stress, and they may not be able to cope well, and they may become ill. Other people will, and those people have repeated episodes, maybe through, and some people, unfortunately, will be ill for much of their life. Usually, say from my experience, the earlier the diagnosis, the worse the prognosis. So we would often, I remember having a person who was diagnosed schizophrenic just in his early teen years, and he always seemed to be actively ill. Other people later in life, they seem to have fewer episodes. Today, we are very lucky that we have treatments to help people with mental illnesses. Medications that we use help restore this chemical balance in the brain, the different neurotransmitters that may be missing or not enough and so on. An example of a neurotransmitter that's serotonin we've mentioned. There's a drug that is used to treat certain types of depression, clinical depression, called selective serotonin reuptake inhibitors, and that's abbreviated as SSRI. And as you see there on the screen, it does say they're used to treat depression, and they help by boosting the serotonin levels in the brain, and thereby reducing the symptoms of depression. So that's just a little bit of an overview, to talk about why people become ill. It's basically because of these disruptions in the brain itself, often with the chemistry of the brain. The most common mental illnesses that we deal with in the mental health program would be schizophrenia, bipolar disorder, which you may know as manic depressive illness as well, and of course depression, and addiction. We see an awful lot more addiction today than what we did in the past. Certainly in the past we had a lot of alcohol addiction, but today we see other drugs, substances being used. What exactly is schizophrenia? Well, it's a psychotic disorder characterized by a loss of contact with reality, deterioration in the level of functioning in everyday life, disintegration of personality as evidence in disorders of feeling, thought, perception, and behavior. So I'm going to try to explain that as we go along here a little bit more. What does this mean, exactly this definition? Well, also with schizophrenia, it's a chronic illness like diabetes. Now, I'm not just comparing it. We know that diabetes is a chronic illness. We know that some people who are diabetic will be able to control their illness with proper diet and exercise. We know that some people who are diabetic may require oral medication, while others will have to rely upon insulin injections. There's some people will have major complications, blindness, they'll have neuropathies, they'll lose limbs and so on, kidney failure. So these are the sorts of things that can happen. We've got a very wide gamut of people who have diabetes. And when we talk about schizophrenia or other mental illnesses, you have the same degree. You have some people who are, do not have too many episodes, as I said earlier, and others who are significantly impaired because of their illness. So I've often found that sort of analogy that people recognize and understand about diabetes is a good one to explain how schizophrenia actually affects different people. The onset is usually before the age of 25, usually in the late teens. And usually, as we know, our bodies changed. We have quite a lot of changes happening in our teenage years, development of secondary sexual characteristics and so on. But we also have a lot of changes in our brain. And this is when quite often people first have an episode. 1 in 100 persons will develop schizophrenia, and mental illness is schizophrenia, is the most common one associated with psychosis. And what exactly is psychosis? Well, it's a fundamental arrangement of the mind characterized by defective or lost contact with reality, as evidenced by delusions, and I'll explain what exactly that is in a few minutes, hallucinations, disorganized communication, and disorganized behavior. The two most common symptoms you may encounter with a person diagnosed with schizophrenia are hallucinations and delusions. These are the things that usually bring people into the healthcare system, and these are called positive signs. Now, when I say positive here, that does not mean that they are good. It just means that there's a strong indicator that this is what's happening with the person if the person is schizophrenic. Now, of course, people can have delusions, hallucinations with other illnesses as well, but these are considered positive markers or indicators that the illness is present. There are also, of course, we have positive signs, we have negative signs. So positive signs are really things that are added, that things that should not be there, these delusions and hallucinations. Negative signs or symptoms are things that are taken away, things that we need to have in our lives on a day-to-day basis to enable us to function within our families, to live independently, to basically be integrated into the wider community society. So these negative signs are often less apparent initially, but certainly when the person comes into the healthcare system, it's quite evident. The staff working with them, they see that. So here we basically have the positive signs are hallucinations and delusions, and I'll explain that in a second. But I'm going to get a little bit more to the negative symptoms because these are the things that actually quite often impair people a fair bit when they're living in the community as well. So apathy, that's one problem. Lack of emotion, and also with that inappropriate emotional response to events like, for example, loss, death. People may respond inappropriately. You think a person would be sad at the loss, but they may have very inappropriate responses. Poor socialization. Poor personal hygiene. As I mentioned about the activities of daily living that you and I do, get up and have a shower and do things like that. Sometimes people neglect these sorts of things, and eating and all these things that we need to do to stay well. Disorganized thoughts, difficulty concentrating and focusing, difficulty following instructions. And with that, my experience with working with people, one of the major difficulties in instructions is actually being compliant with the treatment program. Coming back for follow-up on a regular basis, keeping your appointments, being compliant with taking your medications. So this is one of the major reasons why quite often people repeatedly become ill, because they become not compliant with the care that's been prescribed. Often, other negative symptoms, people will have inexpressive faces, kind of a flat affect, we would say, monotone and monosyllabic in their conversation or speech, very few gestures, seeming lacking interest in other people, inability to feel pleasure or act spontaneously, lack of motivation. So, and that's a big thing, of course, trying to get people to be motivated to take part in programs that we encourage them to be involved with to help them with their socialization. Often, I did mention already the feeling, so people will have inappropriate emotional responses to things that happen in their lives. Thinking, a person has trouble sorting out their thoughts and concentrating. Sometimes I have that problem. I know we all do, concentrating when I'm reading sometimes in courses that I'm doing. I quite often have a nap in between sentences. Concrete thinking. Now, we're able to, as adults, think in abstract ways. So I gave a little bit of a funny story now. I give tours at the Anglican Cathedral in St. John's, and at one point you're actually walking through the organ. The pipes surround you and are above you, and the billows of the organ run beneath the floor. And I always tell people, okay, we're walking through here now. If this caves in, we're going to be organized. Now, you get the understanding of what I mean when I say that. You're able to think in an abstract way, you know what I'm talking about, making a pun. Puns, I don't know. That's me, I'm very punny. But with people who are schizophrenic, find it very difficult to understand that sort of thing. Now, I gave this to children the other day with a confirmation class, and most of them kind of looked perplexed when I said it, because this is something we develop as we get older, the ability to understand that. But I did have one young fellow said to me, he's about 11, so that's the best pun I've ever heard. But with people who are schizophrenic, if I said to a client, okay, I'm going to wash your face off now, that person may interpret that I'm literally going to remove their face. Or if I said to someone, explain to me what this means. A rolling stone gathers no moss. So they would be very concrete in their thinking. Oh, a stone that's rolling, continues rolling all the time, it's not going to get any moss on it because it's moving. So, I mean, we know that that's not what it means, okay? People who are schizophrenic also have very poor or no insight at all. They can be quite ill, and they don't understand that they have an illness, okay? You and I go out, I know when I broke a bone in my foot when I was dancing at Club Max in 1983. Some of you might remember Club Max. I knew I broke my foot. I heard a break. But I continued dancing, though, just the same. I had to finish the song. But anyway, people with mental illnesses like schizophrenia, they have no insight into the fact they're actually suffering from an illness. Quite often they don't. Further characteristics, inappropriate eye contact. I can think of times when I'd be walking through the corridor at the hospital, and I always like to smile at people. And I'd probably smile at a client going through the corridor, and the person would, what are you laughing at? Because they would think a smile or my making eye contact was somehow I was invading, probably even reading their thoughts or what they were thinking, okay? People, and with that, of course, misunderstanding of others, intentions. I was smiling to be basically be nice and polite, but they did not understand it that way. Difficulty communicating, bizarre behavior, sometimes agitation and aggression as well. Now, so those were the negative signs. Now, the positive signs, hallucinations are fairly common, and you've probably heard of people who are schizophrenic have auditory hallucinations. They're hearing voices. This is the most common type of hallucination that a person would have who's schizophrenic, hearing voices. Others may have visual hallucinations. They see things that are not there. This is not quite so common, and this sometimes happens with people with, brain tumors and things like that because of the way the tumor is affecting the brain. Some people will have tactile hallucinations. That's things touch. And again, that's more common with the people with addiction problems, particularly alcohol. If people are in withdrawal from alcohol, they may have a sensation. I remember having a patient say to me one time, she called out to me. She felt she had spiders crawling through her skin, and she was tearing at her skin because she felt that, this was an hallucination she was having, but she, to her, of course, it was very real. Olfactory hallucinations are hallucinations that affect smell. So some people will say they smell something that's very foul odor, feces, that sort of thing. And gustatory would be another type of hallucination. Gustatory deals with taste. These last two are, again, not that common. They are more common, for example, for a person who's epileptic and is about to have a seizure. They will have, they might say, I smell toast burning, or I taste something strange or different. When I heard someone who's not schizophrenic, but epileptic like that, lie down on the floor, get down on the floor. So that's something you might remember. So that way they avoid falling. Persons hallucinating may appear very distracted. And you imagine if you're hearing voices, you're going to be distracted by that. They have an altered sense of reality. They may be observed to be talking to themselves or mumbling to themselves. When I used to do this as a kid, my mother used to tell me I was talking to the devil, or I had money in the bank. Well, I know I have no money in the bank.
Had to be one.
And they, as I said, may exhibit inappropriate gaze because they imagine someone is talking to them, so they're looking towards to where they feel their voice is coming from. Delusion is a disorder of thought characterized by a false fixed belief. In other words, it's firmly held by the person or beliefs with no basis in reality. So, for example, I might say that I'm the Emperor of Newfoundland. Well, obviously we don't have an empire, so I'm only the king. So, no, it doesn't go that way. The person who's having a delusion, as I said, the reality is very distorted. What's real to them, we may recognize it's not reality, but to that person, that is their reality. That's what they understand things to be. You cannot rationalize with that person. You might as well talk to a wall. You cannot rationalize with that person that these thoughts that they have are not real. To that person it is. So that's a failed attempt. And in fact, you will only frustrate that person. And they will become almost, in one sense, almost more grounded because they're trying to support their ideas or their beliefs. Now, I like to try to get analogies of things. What would that be like to have these sorts of ideas or beliefs? So to me, the best way I can describe it is like a dream. Now, when I have dreams about rats or nightmares about rats, it's very real at the moment, okay? But I am terrified of rats, okay? So it seems or appears to be very real. And I'll wake up in a sweat and so on. And our dreams can be very bizarre. Maybe the rat is sitting down at dinner with me and talking to me, or that sort of thing, right? And of course, our dreams are often very disorganized, but they do seem real at that moment. Well, if you think of a person with who's suffering from delusions and hallucinations, at that time. That is their reality. That is what's real to them, just the same as our dreams appear real to us. To watch my time. Paranoia. Now, there are different types of delusions. A lot of people I see in the past have a lot of religious delusions. But you have people who have paranoia, and that's probably the one we're most familiar with. They have thoughts that others are plotting against them to cause them harm. So paranoia is characterized by suspiciousness, avoidance of foods or meds. Some patients I know would often feel that when we were trying to give them medication to help them with their symptoms that they were exhibiting, they felt that we were trying to poison them. Defensiveness, unrealistic fear, because they feel like something's going to harm them. They're uncommunicative. They won't talk to you because they're so suspicious of you that they won't communicate. And they may become agitated and aggressive as a result. And they certainly will mistrust the intentions of others. They might perceive you as the enemy. That's a possibility. Aggression. Now, probably I always used to tell staff that you are certainly much greater risk on George Street on Friday or Saturday night than you would ever be at the Watford Hospital. That's probably my experience. But not that I go to George Street very often. Okay. Most people with schizophrenia would never harm anyone. They are no more violent than the general population. Those that do experience aggressive episodes do so in response to hallucinations that they're having or to delusions that they're experiencing. And the potential to be aggressive is increased dramatically if the person is abusing alcohol or drugs. And I think that Curt will talk a little bit about that in his presentation. So alcohol and drugs with a mental illness, that certainly puts a person at greater risk of aggression. Moving on from that major mental health problem, now we'll talk about bipolar illness or bipolar disorder or manic depressive illness. It's a mood disorder that causes extreme changes in mood or mood swings. Person may experience periods of mania and depression along with normal moods. And some of our greatest artists have been schizophrenic. Some of them, our greatest artists, have been bipolar. It's believed that when Handel wrote Messiah, he may have actually been suffering from a mania at that time to have written such a choral work in 23 days. So people can be extremely focused sometimes and be creative. That's more unusual, but it can happen. 1% to 2% of adults worldwide suffer from bipolar disorder, with men and women affected equally. Although some husbands out there may feel differently, I'm sure. Mania, I say that under peril here now, probably today. Mania, feelings of elation, euphoria, cheerfulness, or sometimes irritability, agitation, and aggression. Now, for me, in my experience, working with people who had mania, I generally found that they were very elated, very euphoric, and they felt on top of the world. Why do I want to take medication for? I feel wonderful. There's nothing wrong with me. Again, no insight into how appropriate this is. They're very active, extremely active, lots of energy. Seems like unbounded energy. I remember having people who never slept for days, really, and but they kept going, just like that bunny rabbit, that pink rabbit you see, the Energizer bunny. People could keep going, and it was phenomenal to think that people would not need any sleep. They have exaggerated self-esteem and can be extremely grandiose as well. Sleep disturbance, as I said, is significant. Very distractible, a very short attention span. I remember having a client, he was losing weight, And he was so active, moving and so on with all that exercise, but he would not sit down to eat. You try to get him to sit down, and before his bottom would hit the chair, he was up and going again. And he might have a sandwich in his hand, you know, that he was eating bits and pieces of, and the rest is just dropping it on the floor. So even in working with people like that in the healthcare system, we had to give them things that they could carry and eat, like a sandwich. You don't have to sit down and eat that, but you can eat something like a sandwich on the move. Racing thoughts, or sometimes what we call flight of ideas. So they're constantly going from one idea to the next, and they will have accelerated speech to the point that sometimes it's very difficult to understand them. Hopefully I'm not talking too fast here today. Poor judgment, making very inappropriate decisions, for example, in driving, or, you know, I'm going to clean my windows now, so I get up on the window ledge in the 6th-story building and they clean the outside of my windows, not considering the risk that I'm putting myself under. So being impulsive, which of course leads to risky behaviors, and again, poor or no insight. Hypersexual and provocative behaviors, and I remember working with some people who, when they were acutely ill with mania, they would be very hypersexual, and then afterwards, when they would come down, they would be so embarrassed by their behavior because they would remember what they had said and done, and that they were appalled, and they would profusely try to apologize for what they had done, but of course they recognized that it was part of an illness. So that can happen as well, and of course that makes people feel uncomfortable, not just the person who's ill, but the other people who are dealing with them. Disorganized, bizarre dress, you know, dressing really inappropriately, and I did mention weight changes already. Now, depression. The people obviously who are depressed have a sad affect, kind of a flat expression, may be tearful, have feelings of hopelessness, suicidal thoughts. And it's interesting because often we think that people who are depressed are at great risk of suicide, and they are, of course, but it's not when they're profoundly depressed, because at that point they don't even have the energy to do anything or to plan to do anything, because their thoughts are slowed down so much. However, when they start to get well, that's when we feel that they are probably at greatest risk, and we have to watch them more carefully at that point. Some people will have agitation and be irritable. Sleep disturbance is another big problem with depression. People have a difficult time initially falling to sleep, and then they wake up frequently throughout the rest period, and then they have early morning awakening and cannot get back to sleep. They may be lying in bed all day with their eyes closed, but in actual fact, they are not sleeping quite often. They have feelings that their thoughts are slowed down or are decreased. They have fewer thoughts, and like nothing's happening in their head, I guess, in terms of thoughts. Other symptoms, difficulty concentrating, making decisions, disruption in appetite. Some people eat more, some people eat less. Generally, people eat less, I found. A lack of interest and pleasure in day-to-day activities, sexual behavior and all these sorts of things, you know, it becomes diminished. Lack of interest in relationships, decreased socialization, energy I've mentioned, and psychomotor impairment. So physically, actually, their movements are slowed down. They move slower, they shuffle and so on, rather than walk at a normal gait. Substance abuse and mental illness. So I'm winding down this part now. I'm not going to speak too much about this, but just to reiterate, persons with substance abuse and mental illness are said to have a concurrent disorder or comorbid disorder problem. There is not a specific group of characteristics for a concurrent disorder. In other words, it's very difficult to say what the symptoms would be because it really depends on what substance the person is abusing, but also the mental illness that they may have. So whether it's schizophrenia, bipolar illness, depression, whatever. So, and of course, again, what drug or alcohol they're abusing that. How common are concurrent disorders? About 53% of persons diagnosed with a substance abuse disorder, other than alcohol, will also be diagnosed with mental illness. So we have a lot of people, we know today have substance abuse problems. Many of them, a significant number, will also have a mental health issue. And sometimes what's happening actually is that we say that a person recognizes that they are sick and they're self-medicating, alcohol, whatever. People who are depressed often drink. And if they feel initially a little bit better, but of course we know that actually alcohol is depressive and it will actually make them feel worse. How does each affect the other? Well, substance abuse may make a mental health issue worse, as I said, like alcohol and depression. It may mimic symptoms of mental illness, or some substances. Obviously, if a person is taking drugs or alcohol, it's going to interfere with medication. And substance-induced psychosis, although substance abuse does not cause mental illness in and of itself, it may induce an episode of psychosis. So we have someone who comes into the healthcare system, they're on some sort of, their behavior becomes very bizarre and so on as a result of the abuse of the drug. Drug-induced psychosis is the most common, unpredictable mental illness resulting in greater risk of aggression. So if a person is abusing substances and have mental illness, they're more likely to be aggressive. And also drugs that are taken into the system, some drugs, for example, they will have an immediate effect. Others will be stored in the body tissue, the adipose tissue, the fat of the body, and weeks later, when that may be released into the system. So it's not necessarily, that they've actually taken a drug today. It might have been sometime in the past that now they have this psychotic break because of what's happening in their body. So a substance abuse-induced psychosis can also be caused by, of course, alcohol, inhalants. We hear about a lot of gas sniffing and glues, that sort of thing. Medications, people abusing medications, or, of course, street drugs. And I think that's it for my presentation. I'll turn it back over to Rick, and if there's time later, I will talk on the Mental Health Act and how it impacts individuals.
And just while I'm doing a few technical things here, Derrick, I'll just throw it open to those who are here, or those who are online, if anyone wants to ask a particular question. But I'll just get you to comment while people are generating a question on anything particular you'd suggest with regard to that pastoral care workers need to bear in mind, particularly on what they can do. And I guess I'm thinking most specifically about people out in congregations where they're trying to deal with a person or a family who are going through some of these issues. Any particular things that come to mind on how to...
Well, the thing that comes to my mind, this is why I wanted to talk about the actual Mental Health Act, because obviously when a person is ill, if a person was diabetic, would you allow them, or they're having a heart attack, or are you going to just try to help them? Yes, hopefully you would, but you recognize as well that they need to have immediate health care. And so if you see someone within a family or within your congregation that's having significant mental health issues, they need to have proper care. And I think sometimes it gets delayed, and people then, of course, they deteriorate, and they end up in hospital probably eventually anyway, and their stay would be longer. So this is one of the reasons why I want to talk about the Mental Health Act, because that is something that would be, I think, important for us to have an awareness of, because how we can use the Act to help a person or family who are having a very difficult time. I just recently had to help some people within my own parish who are dealing with a neighbor who has a mental health problem, and they were trying to help the person as much as they could, and they couldn't understand what was really happening, so explaining the act, I think, is important. Rick, does that help?
Yes, it does, and especially the Mental Health Act and what have you. Later on, I'm going to ask you and Curt to comment on how pastoral care workers who are visiting hospitals and so on, where there might be people with addictions or mental health issues, or visiting other places as well, can connect with the team to better integrate what they're doing. One of the concerns that I've often seen over the years in my work in pastoral care and ethics, pastoral care end of it, in the healthcare system, is that chaplains and other pastoral care workers often felt that, they were involved with somebody, but then when the person got a bit at the hospital or were in counseling with a mental health counselor, addiction counselor, pastoral care worker sometimes wasn't sure if and when and how they could continue to be involved. And it's important for people to know that the pastoral and spiritual component of it is so important, and you can have more confidence and usually more competence as well if you connect with others. And of course, all that has to be sorted out within the ranges of what people consent to and privacy, confidentiality, and the like. But we'll hopefully chat about it a little bit later. Anyway, any question from anyone here or anyone online before we let Derrick move on, and he won't become organized, but he'll become whatever in recess. Yeah. Any question from anyone? If you're online, unmute yourself if you're going to ask a question or make a comment. And someone has asked, will this presentation be available to use with others? Yes, we will have it recorded online, and so you can use it and distribute it or whatever ways it might work. That's the idea of doing it. So thanks, Derrick. We'll have you back again. And we'll call upon Reverend Dr. Curt Clark. Introduced Curt before. Some people have signed up and arrived since we did the introductions. The presenter that you were listening to is the Reverend Derrick Bishop, who's an Anglican deacon but has retired from Eastern Health as a nurse educator, and a lot of his work, but as a nurse and as an educator, was in the area of mental health, and has always been generous in providing education sessions such as this for our pastoral care staff in Eastern Health. And Reverend Dr. Curt Clark is a pastoral care clinician in Eastern Health. He works in the mental health and addictions program, and works in the area of rural Avalon, as well as at the, and by that we mean the Carbonear Harbour Grace area, as well as work at Waterford Hospital. And a lot of his focus is mental health patients, clients, or outpatients, their families, and of course staff who work in those areas as well. So we're great to have you with us. And
very quick to get the next slide.
Yeah. Put the front one.
Okay. So pastoral care to addicts and alcoholics and their families. There's something called the disease concept, and most healthcare professionals and professionals around the world buy into the disease concept. I'm not going to try to sell you on it, but if someone mentions it, at least you're going to know, okay, that's what that means. There's other theories that are out there too. The thing that I like about the disease concept, well, it's the medical model. That's what they call that. And they say the social worker's Bible is the DSM criteria, and that lists hundreds of, 400 or 500 mental health disorders. And in there it lists substance dependence and substance abuse. And the thing that is really nice about this is they say a big part of the treatment for this is spirituality. And so that's the model that I was trained in, and there's a great advantage to that. And so disease concept, to be any kind of disease, it has to have these items that I listed. Progressive, and cancer can start off small and then be progressive and spread to other organs and all that nasty stuff. Well, it's the same with addiction to drugs or alcohol. When the person starts out, their first use is usually, wow, I've been waiting for this feeling all my life. This is wonderful. This is great. Can't wait to do it again. But then as time goes on, everything progresses. Not just the amount that they use. Maybe the first time somebody drinks, they drink 3 beers and they have a buzz and they're feeling good. But then as things advance, they're drinking 24 beers, and then on and on and on. So the amount will progress over time. And it's not just the amount, but all the problems associated with it. So the relationship problems progress. The emotional problems progress. Usually, almost anybody that's an addict or an alcoholic, they fit the criteria for depression. And the drug and alcohol rehab that I worked at, we could diagnose people and say, well, they've got a borderline personality disorder, or they are bipolar. But we were instructed and encouraged to never diagnose someone as clinically depressed, because everyone going through the rehab we could have diagnosed as clinically depressed. So we're just making them aware, saying, well, you have this, but it might be circumstances. If you still have this 2 years from now and you're in recovery, then we need to do something to deal with that. The disease is chronic. There's been people that have had cancers that I've ministered to in the cancer center, and they'll say, well, what I have is not curable, but the doctor says it's treatable. And so they themselves are trying to get their heads around that. And so nobody gets cured of being an addict or an alcoholic. They're like that the rest of their life. However, they can be an addict, an alcoholic in recovery. Potentially fatal. It's got identifiable symptoms, and that's on the next slide. Life deterioration. And the way this disease works, first it kills you spiritually. You might have a relationship with God, but it becomes dysfunctional. You might say, well, there's grace and there's mercy and there's forgiveness. Everybody's going to get that at the church I go to except for me. Somehow I have to work for it. And even though they know in their head, well, that's not theologically sound. I'm like, I can't really work my way into God's grace, but they're thinking, oh, I've got to do that. So first it kills you spiritually, then it kills you relationally, then it kills you emotionally, and the last thing it does is it kills you physically. And that can come in many different ways. Liver problems, kidney problems, digestive problems, type 2 diabetes that's thrown off by drug use or alcoholism. And then the cause. The cause can be known or unknown. In cancer care, there's something that's called an unknown primary. And so when I started working there, I asked Dr. Shea, what is an unknown primary? And I got, well, we don't know where this cancer started. And we don't. But so when it's coming in different areas, that's not the primary thing. And so what's causing this, we don't know. But here's the treatment. And so it's the same with addicts and alcoholics. We really don't know a cause. And some people say, well, is it genetic? And there's some correlations. Correlations aren't causes and effect. If you had one parent that's an alcoholic or an addict, there's a 50% chance you'll be an alcoholic or an addict. If you have 2 parents that are alcoholic or an addict, there's a 75% chance. But that's a correlation. Just because the sales of bananas and cars go up doesn't mean, well, the banana sales cause that car sales to go up. There's also a lot of work that's being done saying, well, it's early childhood trauma. That's what has factored into this. And almost like you could be childhood sexual abuse or witnessing a trauma, or their house burns down, as a 8-year-old. And so it's sort of like, gee, I've gotten bitten. If they never pick up drugs or alcohol, they'll be fine. But once they pick it up, that just sets off that time bomb. And it's sort of like it's out of their control. And so with me, it's not worth spending a lot of effort on it because, going back to the cause, it's more like, let's get this person into recovery, let's find treatment. There we go. So symptoms of substance dependence, and there's substance dependence and there's substance abuse. Substance abuse would be like the perfect storm. The clergy person had their mother die and they were really close to their mother. Their friends, this is in November, their friends all seem to abandon them. They have financial problems, their car is not working. The bishop is not really pleased with them. The Christmas service is over, they grab a bottle and they just don't stop and they end up hospitalized with alcohol poisoning. Well, that person may not be an addict. It might be that was the perfect storm that brought this on. And because of the shame that's associated with that, this person's saying, I'm never going to do that again, and they never do. Substance abuse, that's what that is. It's a one-time blip. But substance dependence, that's different. It's not a one-time blip. The person might be a binge user, meaning they might go a month without touching any alcohol or drugs, and then boom, they use and just keep using for maybe a day, maybe 2 days, maybe longer. So the symptoms are time spent using, and then significant time spent thinking about using. So they might not be using, but they might be thinking the weekend's coming up. Where am I going to get my drugs? My dealer's out of town. I've got to do something to get some money here, and just, boy, that's going to be good. That's going to be fun. And so, just a lot of creative energy wasted. So addicts and alcoholics, it's proven they're the most creative people in the world. Just to stay in their addictions, they have to be creative. This one guy, there's something called the U-Turn Drop-In Center. It's run by addicts and alcoholics in Carbonear, and they have all kinds of programs and stuff. And this one guy from Old Perlican was in early recovery, only in recovery for 2 weeks. And he used to buy his drugs at Carbonear Mall. That's, everybody knows that's where you go. And I said, hey, there's a really great Friday night NA meeting at U-Turn in Carbonear. And he said to me, well, that's too far to go. And I just, kind of waited. And he goes, oh, I know, if they put that same energy into recovery that they did into drinking, and then that creativity spreads, and it just, they can be some of the best people that you have in the church, coming up with outstanding programs and ministries and things that you might not have ever thought of. And leisure time, that's not on here, but that's time spent using. So maybe somebody enjoyed quilting or snowmobiling or hunting or fishing, and all that's gone, because everything is centered around, the drug use or the alcohol use. They still enjoy those things. It's just that time is consumed. Then tolerance, as I said, somebody might start off in 3 beers and they have a buzz, but as it progresses, 3 beers doesn't do anything for them. That they need, more. Withdrawal, and so when the person stops using, withdrawal symptoms could be headaches, it could be seizures or shakes, it could be cold sweats, and that the alcohol is just getting cleansed from the body. Then cravings, and so just like if you're hungry and it's Thanksgiving and that turkey dinner, you smell that turkey dinner, that's a craving. Addicts and alcoholics have that as well, and they can be set off by a TV commercial, or they, or triggered, And so they've got cravings, blackouts. So the person, we had two church organists in this church that I served for 12 years. And the one of them, he was an alcoholic, and he played at the early service. And there's sometimes, like one of the times it was just about funny because he's playing this hymn really badly, and then just slap it, goes, I'm done, But he used to call me very late at night, intoxicated, and he was saying, I'm going to complete suicide. And then I'd go and talk with him and deal with him. The next day, he wouldn't remember any of that. Because I didn't do that. But the problems continued to mount for him because he was caught drunk driving, and so they took his license away. Then he was using a bicycle and got caught driving with a bicycle, and he came out of a bar in Butler, Pennsylvania, and intoxicated, stepped right in front of the car, and the car hit him, and he got up and ran away. And the person called in a hit and run, and explaining, I hit this guy and he ran away. They found him later at the hospital. And so finally, he was a healthcare professional, highly intelligent person. And finally what he did was he called me and 10 other healthcare professionals, and we all were there in his apartment as he's saying he's going to complete suicide, and he had the plan and the means to do it. And so we called an ambulance and got him into the hospital, and he went into the psych ward. And after about 6 days, when the alcohol left the system, he goes, I'm not going to kill myself, but I do need treatment because I'm an alcoholic, and went to rehab. And that was like his recovery. And so when dealing with addicts and alcoholics, they tend to minimize. It's a polite way of saying lying, clergy sometimes might have a hard time calling them on their stuff. But that's exactly what you got to do. Like I visited you last night, you were totally intoxicated, and this is what you were saying, and so that, so he doesn't want to accept that, but that's what's going on. Because only when the addicts and the alcoholics can take a look at the pain that drug use or alcohol causes in their life, that's what motivates them to get into recovery. And so if we, there, it's like, that's probably not a healthy thing for us to do, but to say, you're harming yourself, you're harming others, it's going to continue, And so groups are the treatment of choice for addicts and alcoholics. It's better than one-on-one counseling. And I do a program every Monday at the Detox, and I say, what would happen if, say you're an alcoholic and you walk into an AA meeting and you say, I can quit anytime I want, and these people have had anywhere between 1 to 6 days sober, they jump all over that, BS, only they don't say BS, or how's that working for you, and so even though they're like only got a little short period of sobriety and maybe not recovered, they know, and so for us to call them on their stuff is helpful. Mood swings, relational problems, emotional problems, legal problems, spiritual problems. They could have kids taken away from them. It might not be a divorce, but things aren't good in the marriage because of drugs and alcohol. Friends don't physically do that. They put one hand on their wallet, the other hand up like this, and say, "Oh, good to see you." They know they're just trying to get away. And again, health problems. So if you're not an addict or alcoholic, just think of your favorite food and then be told you can never eat that again, ever. And then you multiply that by about 1 million. That's what the addict and alcoholic feels. And at the Detox, I'll say addicts and alcoholics love a lot of different things on a lot of different levels. But if you're totally honest, what do you love the most? And they know. Whatever the drug of choice is, that's what they love the most. And giving that up, it would be almost like one of the tools that you can use is having them write a goodbye letter to their drug of choice. And it almost sounds like somebody that's with a spouse that batters them. This started out wonderful and great, but then as time went on, this is what you did, this is what you did, this is what you did. So it's very, very, very hard. And addicts and alcoholics are obsessive compulsive, work hard, play hard, drink hard, a lot of black and white thinking, and as they get into recovery, like the rainbow comes out. And usually the last thing for the addict or alcoholic to go is the job. And if somebody, this isn't the way to diagnose addicts or alcoholics, but if somebody's got rules, say rules around drinking, that's usually an addict and alcoholic, because non-addicts and alcoholics don't have to have rules. Like I never drink for 4 or 5 when I'm working, and I never drink before noon on the weekends. That's something to be explored. But a normal person can choose to drink or have a drink or two or stop, or at a picnic, drink half a beer and that's it. They just leave that there. The addict or alcoholic can choose to drink, or they can choose not to drink. But once they choose to drink, they kind of lose that. And it might be, oh gee, I went to the bar and just had 1 beer and that was it. So I'm recovered now. And they might be able to do that for maybe a couple weeks, but then boom, there they go. And all the problems along with it. So for recovery, you need 2 categories of things. One is abstinence, and abstinence means no drugs, no alcohol. One of my clients started using drugs when she was 12, a very abusive family. And by the time she was in her early 20s, she was using cocaine IV, and she was an escort, that's the nice way of saying prostitute, to get the money. She had gone to lots of NA, Narcotics Anonymous meetings. She had been to the recovery center, the detox, multiple times. She went to rehab, and still wasn't getting recovery. And then finally, she got a period of recovery, and then said, "Oh, I should reward myself, because I've got 6 months in, And the girls go out for a drink, and they're going Friday, and alcohol's never been my thing. It didn't do anything for me. So she went out and drank on Friday. Oh, I passed that test. And then said, well, marijuana's never been my thing. I just, I'll smoke a joint once in a while, smoking joints every day, And then back to the coke IV and back to the prostitution and all the other problems for about 6 weeks, and then got back into recovery. And she's in recovery, doing wonderful to this day. And so that's a hard way to learn a lesson. But whatever your drug of choice is, if you start using, so no drugs, no alcohol, and then you need behavior changes, and in that is included spiritual changes, and that's like going to AA or NA meetings. Finding a sponsor. A sponsor would be kind of like a mentor. Like you look at someone and say, I wouldn't mind having the kind of sobriety that they have. And they kind of coach you. It's usually somebody that's got a long time in recovery, working the 12 steps, and we'll get to that. Maybe going to a trauma counselor, because at AA or NA you just talk about the addiction, and maybe something else is needed there. Individual counselor, clergy person. A dry drunk is somebody who has abstinence but no behavior changes, and they're better off drinking and using, in my opinion, because they're really miserable to be around. And some people, they just wait and not clue. But then what happens is, once they're off the drugs or the alcohol, the emotions start to come up. And we'll talk about that in a little bit. And they finally say, screw it, go back to drinking or go back to using drugs to kind of stuff that back down. And they go, oh, I relapsed. No, not really, because it's been recovery. You had abstinence and tremendous willpower. And addicts and alcoholics, being obsessive compulsive, they like to solve all their own problems. Thank you very much. We can keep God and other people out of this. And they come to the conclusion And you're like, oh crap. For this, I need other people and I need God. And we've got to include that in to get the recovery. So emotions, grief, and recovery. So if you think of all the emotions that you could possibly feel, so all the painful emotions and all the joyful emotions, and all these emotions are contained in this great big gigantic beach ball. The long-term effects of drugs and alcohol causes you to stuff those emotions so that they cannot get processed. So you still feel emotions. The alcoholic might be angry about this thing that happened 10 years ago, still feels like last week. So what they'll do is they'll drink. And maybe what happens is this is working good. I just kind of chill out and numb out and black out. And wake up the next morning and it's sort of like the roller coaster ride. You wait in line forever. The ride is fun, but then you get off at the same place you were, if not a little worse. Or the other thing happens. You're angry about that thing 10 years ago, and so you drink and you fly into a rage. You punch a hole in your wall. You're breaking your computer. You're calling your boss on the phone, cursing them out. And, then you get up the next morning. You're still angry about that thing that happened 10 years ago. But now there's more shame and there's more guilt. So stuff constantly gets added to that beach ball. And so a good question to ask someone who's telling you that they're an addict or alcoholic and they want to get into recovery. When's the first time that you took a drink or a drug? How old were you? And most people will say between 10 and 20, like the bell-shaped curve. That's when you're going to capture most. Sometimes I've had people say 5 or 3, and sometimes I've had people say 65. They never touched alcohol or never used drugs, got in a car accident, the doctor prescribed Percocets, and whoom, didn't know this about me. But for them, those life events have not been able to be processed. So that if there's been a death, that's grief and bereavement, they haven't been able to process it. Somehow it still feels like it happened 2 weeks ago. If they had this dream of getting this job and going to school, because of drugs and alcohol, maybe they got flunked out of school, or maybe they got fired from the job, or maybe the employer's wondering, are you going to call in sick again or come in all strung out? And most people aren't ready to deal with childhood neglect, childhood physical abuse, childhood emotional abuse, childhood sexual abuse to their late 20s or early 30s. So it's possible some of that can be in that beach ball as well. And so abstinence, taking your hands off that beach ball, it might not happen the first day, but it will happen. And they think, oh my God, my emotions are going to the moon, and that's why so many people, they don't really get recovery, short period of willpower and abstinence. And that's where you need the other people, people that have been there, they've been through that, you don't have to explain yourself, to them, they can identify. That's AA and NA. But when I'm at the rehab trying to explain emotions to people, I'll just say, can you name an emotion or emotions that you're feeling today or yesterday? And there's painful emotions and joyful emotions. And they'll usually list about 30 painful emotions: shame, guilt, anger, depression, sadness, isolated, lonely. They just, they'll rip that off. And usually I have to add, is anybody here hopeful that you're going to get recovery? Oh yeah, is anybody proud that you're trying to get recovery? Oh yeah. Because it's there, but what they're seeing is the painful emotion list. And so grief is a cluster of emotions, and it's really hard to identify in early recovery how you feel. And because it's like I feel 35 painful ones and 10 joyful ones, and they're all wrapped in there together. And if you ever put had a cut and you put anesthetic on it, that burns. And so people who are in early recovery, it's like, gee, I had this wound, I've been putting makeup on it trying to hide it, but it's infected, it hurts, I could lose my arm, it could kill me. But if you put that anesthetic on there, it burns, and that's what is happening to them. They go, I'm not using drugs or alcohol, and I feel worse. Yes, But what can happen is this can turn into a scar where you say, okay, that happened, but it doesn't hurt me anymore. It's not renting space in my head. And so people are thinking I'm not normal, because I'm feeling all these emotions. No, it's normal. And you can have like 30 pots of things that you have to deal with. I've got relatives that are very, very stubborn, and the smoke detector went off. And that's what anger is. It's a smoke detector. And they argued, husband and wife, they argued for 10 minutes who's going to check the smoke detector. Finally, one of them went up. The attic was on fire. There's even a fire extinguisher there, and the fire extinguisher did nothing. Had to call the fire company. So the fire company put it out, but there was a lot of damage, and it took months to repair and fix the damage. And so addicts and alcoholics are used to instant gratification. Take this, feel good right away, long-term pain. This is the other way around, and so they've got these fires that are burning. So to process the emotions where, like if you're in recovery and your boss is being a jerk, you might be angry about that for maybe 5 minutes, and then you process it, move on. But here, there's things that, it's going to take a while to process this. And you don't have to do it all at once. It's okay to say, yep, I've got all this stuff. I'm going to put it to the back burner. But this is the one that I'm ready to deal with today. So I call early recovery actually 2.5 years. And so, in 2.5 years, if they stick with abstinence and are putting the behavior changes into place, all those emotions and events can get processed. And so what they would like to hear is it's all going to be gone by Friday, but they know, yeah, it can be gone. But unfortunately, it's going to take a while to do this. So how do you process the emotions? Commitment to the truth, no matter how painful. When someone would come into rehab, there would be a part of them that wants recovery, but the bigger part of them still wants to use. And maybe they're hoping to find, like, maybe I can get some tips to help me with my drinking or whatever. And so we would do group therapy in a 28-day hospital stay, Monday to Friday, about 2.5 hours every day. It would be myself and 6 addicts and alcoholics, no more than that. And I would at first give them little assignments to do, but then I'd give them their big assignment. And this is what you could do, is if someone comes to you in your church and they say, I'm an addict and alcoholic, I'll suggest AA, NA, there's a lot of things you can suggest, but here's something you can do. Start at that first drink or first drug and start to list all the pain that drugs and alcohol cause in your life. The relationship pain, the legal pain, just on and on and on. Status pain, functional pain, how it's affected your body, the role pain, and it's a book, but by the time they write all that, and then the next step is allowing yourself to feel the anger. A lot of addicts and alcoholics are told you shouldn't be angry. You feel how you feel. Like people can say, in this room here, it's the same temperature. We might have somebody that says, I'm hot, I'm cold, I'm just right. Who's right? All of them. It's just how they feel. So your anger, you can't help it if you feel angry, but you're 100% responsible for your behaviors. So it's learning how to go immediate and go direct. And they haven't been able to go immediate because drugs and alcohol kept them from processing stuff. And so there can be some very big anger. But that doesn't mean that they have to drink or use drugs. That's the main way addicts and alcoholics handle anger, or violence, or passive aggressive, or sarcasm, or depression, or all those other ways. And then allowing yourself to feel the sadness. Anger is never the primary emotion. Sadness, hurt, rejection, a boundary's been crossed, you've been abused, could be 100 things under there. And then talk about it out loud with another human being. Now they don't don't do that at the AA or NA meetings, because you might overshare, and, gee, I was sexually abused as a child. I don't know if that affected my drug use at all. Then they go, oh, I can never go back there again. So that's done with a counselor. That can be done, in confession to you. That can be done with their sponsor. So they've got a lot of different avenues there. And then just telling your higher power how you feel, asking your higher power to come and touch it. The guys that started AA, there's 2 people that started it, and what they called, they did use the word higher power. They used Jesus Christ, But as time went on, they changed that to God and then to higher power, because there's some people that don't understand that religion and spirituality can be 2 different things. Dysfunctional religion, that's what killed Jesus. And so, but there can be functional religion that helps you with your spirituality. But if you're talking about Jesus Christ, they might not ever go there. But if you're saying higher power, that's like a step in the door, and then they can explore their own spirituality, So when you're talking about the 12 steps, these are basically the first 5 steps. I just changed the words around, and so that's why working the 12 steps can help. And so types of losses in addiction, material, status, relationship, functional loss, role loss, and self-worth. I didn't have self-worth on the list, but I was being battered by people at the detox center. Self-worth, you need to write that on there. So it's like, okay. That's a big one. Yeah. And so things that you can suggest to parishioners that are looking for recovery, like support systems, like AA, NA, Friends in Recovery, counselor, just people that they can talk with, sponsor, work in the 12 steps, new people, new places, new things. One guy that was in the drug and alcohol rehab, his drug of choice was rum, and he came up to me before Christmas, and he was crying. I thought someone died. And the first words out of his mouth is, "Curt, I'm not going to be able to drink at Christmas time." I thought, whoa, he's thinking about recovery, because he had lost everything, and that didn't matter. But he lost his job, and his boss said, "I'm going to fire you because your drinking is out of control, or go to rehab." So he went to rehab to learn to control his drinking. A lot of people will do that with not the right motives, but they can change into the right motives if you're looking at the pain that it's caused in your life. And so that's what he did. And he goes, "I can't go to this bar. I could go to this bar saying I'm going to drink Coke and play darts, but I know in my heart I'd really be wishing that I was drinking rum and Coke. And I could do that for maybe months, but I can't go there anymore." And then his best friend's an alcoholic. His best friend had wished him good luck, but he had the insight to say, "Well, my best friend's not going to stop his drinking. I get into the truck, there's always a bottle in the glove compartment." And so although new people, new places, new things sounds wonderful, it means saying goodbye to the old people, old places, old things, and that causes grief, even though, hey, this is going to be a good change. No, it causes grief. The 12 steps, I've got them up there, and I've had people say, "I'm going to work the 12 steps in 6 weeks," and that's like, I'm going to build a Toronto skyscraper with no foundation. How's that working? If they get step 1 in the first year, they're doing good. If you get step 1, 2, and 3 in the first 2.5 years, that's doing good. And by the time you do step 4, you need to have about 12 people that you can call, because a lot of people relapse when they're really taking a look at that inventory. It's that's sort of like, list all the stuff that you've done because of drugs and alcohol, and all the stuff that's been done to you because of drugs and alcohol. So that really gets heavy. And if you only have one person to call and they don't pick up the phone, you're done. But if you have a dozen people, by the time you get to 5 or 6, somebody's going to respond. All right. So these stages aren't nice, neat stages, but when someone is going through recovery, they're experiencing grief. They're saying goodbye to their best friend. And C.S. Lewis wrote this book that was called, I think it's called The Great Divorce, instead of Marriage Between Heaven and Hell. It's a little thin book, and all these people are on this bus that's going to something that sounds like purgatory. It decided whether they're going to push in or not. And this one guy has got this clawed creature. It's almost attached to him. The claws are in his shoulder, and it's saying nasty things to him, all the time. And people are making these decisions, and like 40 or 50 miles away is where heaven is, so they're walking. And so this guy decides to make the decision, and this creature just withers and falls on the ground and transforms into this beautiful white horse. And he gets on the horse and he rides it and passes everybody along the way. And so that's sort of how it is for someone that enters recovery. It's like this thing still is a part of me, but what was affecting me and causing all this pain, emotional, spiritual, relational pain, that then transforms. So again, if somebody is thinking about recovery, a tool that you can use is have them write a drug and alcohol written history. Start that first drink, list all the pain, come in, we'll talk about that. Yeah. And as I said before, there's a ambivalence. Part of that person is going to want to have recovery, but the stronger part of that person is still hoping to use. And it's only by the pain, by feeling the pain, that's what will motivate that person to enter recovery. And we covered most of that. And what churches are good at ignoring, it's the alcoholic or the addict that has the problem, but it's the family, and if someone is married to an addict or an alcoholic, they have more issues actually than the addict and the alcoholic. And they can be ignored at church as far as, well, they've got it together, No, they need help too. The most dramatic example is this guy named David. David had no context for church or Christianity or the Bible or anything, and we had a kids program, and he showed up because the kids were singing Sunday morning, and he felt loved. So he started coming to the church, and he came for about 3 years. Came up to me one day and said, "You know what? I think God wants me to stop using cocaine." Yeah, that sounds like God. And so what he did, he got into rehab, but the day before he went, he stood up Sunday and announced to the church that he was a cocaine addict and he was going to enter rehab. And everybody clapped for him. And this is a church that people don't clap. And these old ladies in the church, they're probably younger than me now, they had a card writing campaign.
Oh.
And the rehab was saying, "What is this?" Every day, a stack of cards.
Yeah.
And so he broke that taboo, and entered recovery, which allowed a whole lot of other people to enter recovery. And we ended up having a Sunday school class of 75 people for those that wanted Jesus' help in recovery. I mean, some of the churches I served didn't have that much people. But about a year into it, his common law wife, Teresa, it's Christmas Day, and I had little kids at this point. They're opening presents, and I got a phone call from David. "Curt, you got to come over." And I just said, "David, we're opening presents, and the little kids are here. They're excited." And he goes, "Well, Teresa gave me an 8-ball of cocaine for Christmas and a flask of whiskey."
Yeah.
And so I went over, and see, David was always the bad one. David was always the one that was late, always the one that you couldn't count on. You know, he was a plumber, and he would do some side jobs for cocaine and all the behaviors that go with it. And it was changing the dance. They were used to dancing this way.
Yeah.
David's dancing different. Now Teresa has a choice.
Yeah.
She can change or stop dancing. You know, I can remember her just crying, what do normal people do? I don't even know what normal people do. And you know, her past, you know, with so much childhood abuse and stuff. And so that was given her the choice.
Mm-hmm.
Do I want to deal with this, or do I want to avoid and run? And so when someone's getting recovery in your church, the whole family, you know, and it's affected kids, you know, and so there's things called adult children of alcoholics, and there's Al-Anon groups, and Al-Anon would be very, very good for someone who is living with an addict or alcoholic. There's Nar-Anon groups as well. That's for someone who is living with a drug addict, or you know, and so those groups help the people to see, oh, this is how I'm enabling, and what behaviors in me need to be changed. Yeah, I had a cousin that was an alcoholic and a bricklayer, and he would go from the job with the guys right to the bar, and then his wife would have dinner ready for him, and he might not come home till 8 or 9 o'clock at night, and she was enabling him. But one day, because she had been attending Al-Anon, one day he fell asleep with his mashed potatoes at the table, and she left him there.
Mm-hmm.
You know, and he got up the next day, call my boss, tell him I'm sick. She goes, I'm not calling. You call him. You know, if I call, I'm going to say you were on drunk last night, you're hungover, you fell asleep with your mashed potatoes. You know, and so that was a key moment for him. He didn't decide on the spot, but a couple months later, after attending some meetings, you know, decided to get into recovery. And so sometimes it's confronting. Sometimes it's like, no, bailing your child out would be the worst thing to do. You know, people, oh, that's not love. You know, well, you know, if you keep making it easy for them, there's no reason they're going to change and want to enter recovery. You know, and so that's hard. You have to walk, you know, not just the addict through it, but the family as well. Okay, and relapse can only happen if there was recovery. We had in the church that I was at for a dozen years, we had a church van. Said the name of the church and the phone number. And this guy didn't have a vehicle, so what we did was he was willing to pick people up Sunday mornings, and we had a senior center, and you know, he was willing to drive people around. He was an alcoholic in recovery, and what happened was he was a police officer that was shot, and finally he won a great big settlement, and I knew he relapsed because we were getting phone calls. He was going from bar to bar to bar, and we were, you know, your church van went by, and the van driver yelled out the window, "F you, you." Just kept getting the phone calls, you know. But with him, that was it was probably not a relapse, a lapse. You know, he did that. You know, the next day, right back into absence and recovery, and you know, it stayed in. You know, so there's lapses, which means like a one-time rare event, and people can write out their relapse history because they know what they're going to use, they know how they're going to get it, and it's sort of like a point of no return. As things like it might start off with isolating or feeling anger or something, and you know, it just keeps going down, and then you get the point of no return. You know, here's when they actually use way down here, but nothing's stopping them now. So learning to make those phone calls, you know, and reaching out, you know, so that's another thing that you can do with someone who's in recovery is, you know, have them write out their relapse process and talk about that and make a plan. Any questions?
Any questions for Curt? Very interesting stuff once again. Not on way yet. There might be someone online who'd have a question either, so we'll just say, and I noticed someone typed in a comment. I'll check what that is, and in the meantime, we'll get Derrick back in a few moments to give the short section on the Mental Health Care and Treatment Act. But in the meantime, anyone have any particular question for Curt on anything that he presented? Very interesting, very helpful.
What the symptoms and that you're describing seems to be much wider than just alcoholism and abuse. I mean, behavior people can be controlling and this kind of thing. Would you like to say a few things about that?
Well, somebody who's an active addict or alcoholic, there's going to be a lot of dysfunctional behavior there. But what I gave you with the symptoms, that's what's in the social worker's Bible. That's what's in the DSM for diagnosing substance dependence and substance abuse.
I guess what I'm trying to ask is that, there can be, instead of taking substance abuse, they can, I mean, for example, I was addicted to obsessive thinking. When things went wrong, I just go around and round and round and round in my mind, and some of the same symptoms.
Yes, that obsessive compulsive behavior.
With the same results in terms of relationships.
Yes.
That's one of the things that stands out, of course, in these presentations, both Curt's and Derrick's, is that just seeing a symptom or two and jumping to the conclusion that it's a particular condition or disease or disorder is enough. I mean, there's a lot of clinical and technical considerations to give someone a diagnosis, but you don't need a lot of that to be able to know when someone's having a problem. And I guess that's the point in why we have this session today and these types of things, is that pastoral care and type of pastoral and spiritual support that can be offered can be helpful pretty well anyone who have problems. And as your comment is leading us to, I mean, there are all kinds of other things, of course, that are addictions as well as the things that involve a substance or a chemical. I mean, people are addicted to gambling, which doesn't involve, but it's certainly destructive of lives. I mean, workaholic is a common term, and many families are destroyed by it, And then you got
Sex and
pornography.
It's a massive issue in church communities.
And addicted to money.
Using the most of it right now.
So there's a lot of different factors indeed, and but the focus that I asked her to focus on, and did a very good job on, thank you, Curt, is on matters, particularly substance. But many of the features apply to other things. A couple of questions that are put here in, and I'll bring them up. Either Derrick or Curt might want to address them. One is, why is it that sometimes someone who is depressed seems to be so happy? Maybe Derrick, could you to comment on that when you come back to do your section on the Act. And another question there that says that there's a 12-step program and a faith-based program that runs at the worship center in St. John's for anyone with addictions, hurts, and hang-ups. It's called Celebrate Recovery. Thanks for giving us that information. And will these notes be available following the session? Yeah, well, these are recorded. They'll be available online for those who want to record them. And Curt and Derrick, I'll ask you here, can I make your slides available if someone calls and asks me to? So the slides, you just send me a note, folks, r.singleton@mon.ca. I'm checking my email occasionally. For those who are in the room who see me doing what I always tell students not to do, not to be checking your devices when you're here. But my reason for doing it here is because I'm getting emails from people who are asking about technical things, how they need to hook in and what have you. So I'm going to ask Derrick to come back and do the short section now for us on the Mental Health Care and Treatment Act. So my email address is r.singleton@mon.ca. I'll ask again, though, any question or comment from anyone online? Okay, and here in the room, anything?
So in terms of some of the things that are going on at the worship center, I think that's probably our friend Dolores that talked about Celebrate Recovery. Celebrate Recovery is a 12-step program, which is a faith-based program for people with hurts, habits, and hang-ups. Many of the people that attend do struggle with addiction. Others are there because of childhood trauma, grief, divorce, various other kinds of issues. So that meets every Wednesday evening from 7 to 9. The first part is worship and teaching or testimony, and the second part is small group for men and women. That's every Wednesday, 7 to 9. In addition to that, Celebrate Recovery has small 12-step groups for men and women, which are very, very helpful, and where people are actually working the 12 steps. Another thing, an initiative that we have at the Worship Center, which we began about a year ago, is called Hope Mental Health Ministry. We went to California, where there was a huge international conference on the church and mental health. Probably some of you are familiar with Rick and Kay Warren, pastors in California who had a son with mental health issues who ended his life by suicide. And they have developed a mental health ministry. And we went to this conference, about 3,500 people. International, it was just amazing. And we came back, Joy is involved, I'm involved. We have a leadership team. We have educated volunteers. We've done group training. And we have now, we've sort of been challenging stigma. We're educating ourselves, and we have begun support groups, which are faith-based. We're using faith-based curriculum. We're not in any way opposed to appropriate medical treatment and support that absolutely. And we feel like the church has an essential role in healing for people with mental health issues. So every Monday evening, we are doing support groups for people with lived experience of mental health issues or mental illness, diagnosed mental illness. And we are also doing groups for people that are supporting, caring for, or family members or friends of people with mental health issues.
Great, thanks for telling us about that. Excellent.
Thank you very much.
That's great, good to know about. And those who are hearing it online and those who will hear it on the recording will know about it. So thanks for that, and good to have. I'm going to pass it back to you, Derrick, and you might just take a comment on the question that was asked about people who have, who are depressed, but they seem so happy at a time. Any comment? Or?
Well, I guess we all have periods in our lives when we're sad. That's a normal thing, and we have periods when we're very joyful and happy. So that can happen, of course, to people who are diagnosed with depression. With depression, individuals are usually, the symptoms that I spoke about, they have those symptoms, that sort of impairment for a period of time. So the overall mood is of sadness, but then again, I mean, obviously there would be periods of times when people feel a little bit better, and it might be, for a few hours or whatever. But I know that helps answer the question. And Curt, did you have anything that you could add to that, or you might?
That was good.
Okay, we'll move on. Now, as I said, when Rick approached me a while back about doing this session, and the first part that I did on mental illnesses, I said to him I wanted to talk about mental illness, specifically what are the symptoms that people have, because there's a lot of misunderstanding and misinformation out there about these illnesses. And but I also mentioned to him that I thought it was important to cover the Mental Health Act. And one of the reasons being that I was working with a couple of people who are trying to help a neighbor who was certified under the Mental Health Act, and they had a lot of misunderstandings about the act itself, and I think probably an anger towards the family of the individual who ended up being certified, because they felt that that the family had forced this person into the hospital and they didn't need to be there. So, or at least that's what they felt. The Mental Health Act is there for the treatment of people with mental illness, and it's there to protect them in situations where Could be making very inappropriate decisions, or things that could affect them financially, their relationships, but also, of course, people who may even commit suicide. So it's there to treat people and to offer them protection during a period of time when they are very vulnerable. Let's see if I can get the slide going here. I'm not sure how I get out of the corner here. But the majority of individuals receiving mental health treatment usually do so on a voluntary basis. So people usually recognize, you know, if they have a depression, whatever, that they need help. They need to enter a healthcare system, either a hospital or they need counseling, whatever, in the community, and they seek out that help. So it's a voluntary thing. However, we recognize as well that there are people who become so ill, and as I mentioned earlier, they may not have an insight into their illness. That group of people need to be in a healthcare system to receive treatment. So they require detention and treatment on what we call an involuntary basis. These individuals are admitted under the Mental Health Care and Treatment Act. And this act now has been in place, certainly close to 10 years. I'm after getting the exact date now, the legislation changed. The purpose is to provide for treatment and care and supervision of individuals with a mental disorder who may exhibit dangerous behavior or experience mental, physical deterioration or impairment. So sometimes, I mentioned earlier to you that people with a mental illness may not be taking care of their physical needs, such as eating properly or their personal hygiene, paying bills and things like that. All these things go by the wayside sometimes when people are impacted by a mental health problem. So obviously, when a person is certified under the Act, not only are we hopefully helping them with their mental health problem, but we're going to be working with them with these other problems as well. Because as they improve in their mental health state, these other issues will hopefully be taken care of as well. We want to protect the individual from causing harm to himself or to others, or herself or others, and to provide the least restrictive means in the apprehension, assessment, observation, and treatment of the individual with a mental disorder. Definition of a mental disorder very quickly. I've covered this really already, but it's a disorder of thought, mood, perception, orientation, or memory that impairs the functioning of that individual. So their judgment of behavior is impaired, the capacity to recognize reality is impaired, or their ability to meet the ordinary demands of life. Like I said, taking care of your own personal daily needs, food, and so on. Psychiatric care is always advisable for these individuals if they don't have that insight. So basically, it's a rights-based approach. We don't want to be taking away people's rights. But obviously, there are times when that has to be done. You can think of examples that people may be giving away property that, or writing wills and sorts of things like that. When you write a will, you have to be of sound mind and body, correct? So we don't want people making decisions that they will down the road regret and would put them at significant risk. So but we try to obviously help that person regain the ability to make those proper decisions. The person who is certified has a right to receive a copy of their certification papers explaining or outlining why they are brought into the healthcare system under the Mental Health Act. So they must receive a copy. They are informed when and where they're going to be detained. So we're going to take you to the Health Sciences Psychiatric Department, or we're going to bring you to the Waterford Hospital, wherever they're going to be transported to. They have to be told where they're going. They have to have access to telephone and to visitors. Visitors may visit within, of course, visiting hours. And with the telephone, if you see there on the slide, safety assess, well, we thought that if someone might harm themselves, like with a cord on the phone, that sort of thing, well, we would take those things into consideration. The person has the right to send and receive correspondence, letters, and they have a right to access a lawyer, to have a lawyer speak on their behalf, and to have what's called a review board held to challenge their certification. And they should have the opportunity to be involved with their own care and their treatment. So they may, for example, if I was diagnosed with a mental illness and it was felt that I need to have certain treatment, let's say certain medication, the person might say, well, I really don't want to take that drug. Is there something else? I had that drug before and it caused a side effect, and I'd rather something else. Well, we will take their request into consideration, and it might be that we would try them out a different drug. Ultimately, in that situation, however, the psychiatrist would have the authority still to go ahead and treat the person with the medication that they felt is probably the most beneficial for them, or any other treatment they require. Sharing of information. There are some individuals who agree to have information shared with family or friends. This question is usually addressed with the individual upon admission to the hospital, and it would be documented. So in other words, a person is saying that I will be willing to have my wife or my spouse, whatever, be involved with this, or a parent or a neighbor, as in the case that I mentioned earlier. But of course, they have the right to. So I don't want anybody involved with my care. So I'd say a good many people, when they come into the system initially, they don't. They feel that their family may have been involved with their admission, whatever, and so they choose not to. But they do have that ability. And of course, the thing is, they may know you as a person, their clergy, whatever, or their spiritual advisor. You might be the person they might select to be involved with getting information. We'll talk a little bit more about it in a few seconds. So what is the process itself? An individual can be assessed anywhere. It could be in a hospital, it could be in the doctor's office, it could be in their own home. And in their assessment, it's determined that they meet the criteria for certification. The first certificate can be signed by a GP, a general practitioner, or a nurse practitioner. We know many communities in the province, there may not be a physician in the community, but a nurse practitioner would be there. That person would be permitted to sign the first paper. That first paper will allow treatment to be started and to actually bring the person into a healthcare facility, or somewhere safe where they can be held until they can be transported to a healthcare facility. The certified individual would then be transported to a psychiatric unit, and there's a number of those in the province. Western Memorial would have one. Certainly the Waterford Hospital has some, and the Health Sciences here, the Janeway Hospital as well, has a psychiatric unit. And there they will be assessed by a psychiatrist to determine whether the second certification paper will be completed. And that has been done within a period of 72 hours, okay? So that's from the signing of the first to the second paper is that period of time. However, there is also extenuating circumstances. We know that our geography in Newfoundland might mean that a person can't be transported very quickly, so sometimes those hours can be extended. If the second signature is not completed within that period of time, the person is now voluntary again. And they may choose, they might say, I want to leave, and then we might get somebody else to sign another paper, so they're held again. Note here, providing treatment without consent must always be in the individual's best interest, although it is ultimately the psychiatrist's decision as to what treatment will be ordered. Now, you've all heard about electroconvulsive therapy, or ECT, or shock treatment. And sometimes this is a treatment that has been used for people who are clinically depressed, and it may be the only treatment that in the past has helped them. I've seen people who were never helped with medications, despite we tried many different medications to get them out of the depression, but they did not improve, and ECT was the thing that actually helped these individuals very quickly. So sometimes the person may not want that if they are certified. The psychiatrist does have the right to say, no, this is the treatment we're going to give you, and we'll go ahead and give it, and that's what will happen. But as I said, we try to take their wishes under consideration. Now, the patient representative would be, as I said, this family that I mentioned earlier. They took on that role of actually being like a patient representative. They advocate on behalf of the certified individual. They have to be 19 years of age or older. They must be mentally competent. They will receive the same information that is given to the certified individual, the certification papers. They will be given the same information as well. And obviously, they have to understand that this information is confidential. It cannot be shared with anybody else. The patient is giving the consent for them to have that information. And of course, the person may not want to take on that role. They may refuse to do that. We always encourage, however, a patient if we have someone they suggested to be the substitute decision maker, if you want to have somebody else, if this person is refused, is there somebody else you might consider? And if they say no, well, we'll actually then start saying, well, would you like your next of kin? And we'll go down through the list of people who would be legally defined as our next of kin. Is this an individual you might consider? So, but again, the patient has a right to refuse to have that person put in place. If you're named as a patient representative, you will have to decide whether you can actually fulfill that responsibility. A nurse will notify you and ask you whether you accept this responsibility. Your name and contact information will be added to the chart if you choose to actually represent the patient. There are pamphlets and information that's available for those people so that they can understand exactly what is expected of them. I mentioned about the review board. A person may, when they speak to their lawyer, they may say, I want my certification challenged, and if they do so, the review board has to meet in a timely manner. I'm sorry, I'm not forgetting the exact limits of time, but they will review the person's certification and what's happened. People will come and give witness as to what's happened, why the person was certified, and so on. And then the review board itself will make the decision whether the certification can be overthrown. And quite often, because the person has been treated now for a period of time, they are actually on the road to recovery. They are becoming well again. So that might be overturned then. Interhearing, that's pretty well, I've covered that, I think, anyway. Authorized patient pass. Sometimes as a person improves, as I mentioned earlier, kept in a healthcare facility for a period of time, but as they receive treatment and improvement is shown, it might be decided that this person should go out for a period of time, hours or a day or a weekend, whatever, to be with a responsible family member or friend. So we want to basically see how they manage being out of the supportive hospital environment, how could do for a period of time. And that will help us then determine whether certification can be ended and the person would be made voluntary. And if they so choose, they could actually, leave the healthcare system at that point, leave. The role of the police, excuse me, sometimes if an individual becomes very ill, families may not know exactly what to do, and the police may get involved. They may contact the police themselves, or other people might. And the police do have the right under the Mental Health Act to retain a person and bring them to an area where they can receive assessment to determine if they need to be certified. And also, so the police may actually go into the person's home and remove them, bring them to a healthcare facility. And they might be certified, let's say, in a hospital in some other part of the province, like on the Muir Peninsula, as an example. And then the police could be, it need not be the police, but if it's deemed necessary, the police could be the people who would transport the person to a psychiatric unit, which I mentioned could be at the Health Sciences at Janeway, the Waterford, within Eastern Health. Okay, so the police can be involved. That's something we'd like to see, I guess, happening all the time, but you know, it's a health problem. We don't send the police when someone's having a heart attack. I think myself personally, it's unfortunate that we often send them when someone dies at home and they show up in the funeral home and paramedics and so on. But anyway, that's just my feeling. So the police officer may also be asked to escort the certified person, as I said, to a hospital. They don't always have to be brought there by the police. They can be brought by an ambulance or family. Now, for further information about the Act, there's a website there that I've listed, and that gives you all the forms. There are forms that has to be filled out and information about the Act itself, the role of the patient representative who is sponsoring or working on behalf of the patient. All that's there within the Act. So if you have any questions, I'll try to answer them. The Act allows, by the way, for a person to be detained for a period of time, and then after that period of time, if they're still if they still need to be certified, we can increase the time over time. We can increase it.
Great, thank you, Derrick. Any questions or comments to Derrick before we move on? We're almost at the end of our time, but is there anything that anyone would want to point out or ask about? I will say that if you have something specific that you need information on, you can send an email to me and I'll pass it on to Derrick and or Curt, and I'm sure they will respond to you. And also, if you want copies of their slides, you can send an email to me to request it, and I'll send them to you. And I just want to mention that this session is being recorded, so it'll be available after a day or so on our YouTube. We'll send out it'll be on our Queen's College NL.ca website, how to link it on YouTube. And so tell others as well about this. One of the things that I would say for pastoral care people, if you're in a parish, if you're in a congregation, it's good to go to orientation in the local healthcare system, or to even call and ask whoever looks after pastoral care at the hospital or within the area what orientation they have and what information they can give you about how you can connect and get more information about the mental health services available, so that you can do what you do in pastoral and spiritual care and connect with other healthcare professionals as well. This has been a great session. Thank you, Derrick, and thank you, Curt, for providing the information and making it practical and easy to understand for our participants and attendees today. We have about 25 or so between here and online, maybe closer to 30 actually, and also many who will view it by the recorded sessions. I just want to mention to you that we have two specific sessions planned, and others further up the pipeline, we might say. But on February 7th at 9:30, we have a session on the theology of money. Now, who wouldn't want to attend that, the theology of money? And the presenters for that are two people. The Anglican Church of Canada have just produced a paper. They've had a task force working on that very topic. And so it's very interesting. It deals with ethics, about investments, and all of the matters that influence how we think about money and how we probably need to adjust our way of thinking of it in terms of stewardship and what have you. So that promises to be a great session led by the Reverend Jeffrey Metcalf and the Reverend Maggie Helwig of Toronto. Jeffrey's from the Diocese of Quebec, so we're delighted to have both of them agree to present that session. And also then on March 9th, we have a session on spirituality in the senior years, subtitle Aging, Wisdom and Grace. Same thing, 9:30 to 11:30, and that session is going to be presented by Sister Elizabeth Davis, who has, of course, a reputation across the province and beyond as a leader in healthcare. She's leader of the Sisters of Mercy congregation, and one of the big challenges they have, of course, is the aging population of their membership and her concern for seniors and aging people generally. And we are all aware, becoming all aware as we age, that the whole understanding of life, the meaning of things, and how we manage matters in our life, and what we hope for and respond to things, all of that is spirituality and prayer, and it all changes as we age. So Sister Elizabeth is going to lead us in that session. And we have some others further along we'll be advertising eventually. But thank you all for your attention. Thank you for your attendance. And as I say, these sessions are recorded and available to anyone who wants to attend or to access them online. So unless there's something urgent that anyone wants to share, we'll wrap it up right here now. Going once, going twice, gone. Thank you all. Best of luck. Have a good day.
That's it.